everyone, and welcome to our webinar on an update to wastewater and the coronavirus. I'm Wendy Wert, president of the California Water Environment Association and a civil engineer with the Los Angeles County Sanitation Districts. Today, we're going to provide an update on what agencies are doing to continue operations and support staff. Today's webinar will provide up-to-date information about the coronavirus, potential transmission of the disease through our wastewater systems, research that could potentially help public officials manage this pandemic, and planning for operations during this situation. WEF and CWEA want to provide our members with verified information from nationally respected sources. I am not able to, oh, there we go, yay. So because we have such a great attendance, we are not able to use the raise hand feature. So please put your comments in the chat box and then put your questions and answers in the Q&A as we proceed. So that's me. The sanitation districts manage wastewater for more than 5.6 million residents in Los Angeles County. We also operate a solid waste management system that provides for the needs for about a quarter of our county. Since the outbreak, we've been closely following developments and we've taken actions that are protecting the health of our workers, the general public, as well as the environment. We are adapting and staying connected. For example, our leaders hosted the first ever Sanitation District's virtual town hall meeting yesterday. This interactive forum gave employees an opportunity to ask questions in advance, and then our leaders responded directly during a live broadcast. More than 800 of our employees attended this. We've invigorated our technical staff presentations through live webinars to allow employees to continue learning from one another. We are constantly meeting and we're reviewing the latest guidance and information which changes daily. So we're continuously updating staff with timely information, such as this flyer posted on our employee portal. We're even keeping the public on our radar. So students, teachers, and members of the public got up at 8 a.m. last Saturday morning to join the sanitation districts for our first ever virtual tour of the Bixby Marshland. We're broadcasting from our remote workstations into the communities that we serve. We're also recently starting research that could potentially help public officials manage the pandemic. Studies show that the coronavirus is present in the feces of infected individuals. Genetic material, RNA, not the viable virus, has been found in wastewater entering our plants. We've started taking daily samples of wastewater entering our two largest facilities. That's the Joint Water Pollution Control Plant in Carson and the San Jose Creek East Water Reclamation Plant in Whittier. Because treatment plants collect wastewater across large regions, measuring the level of RNA in untreated wastewater may provide insight into the percentage of people infected. Sanitation district staff are measuring RNA levels using the tests that the CDC developed for patient diagnosis in the US. We're also sending samples to researchers at the University of Arizona, providing samples for a project sponsored by the State Water Resources Control Board, and we're providing samples for studies conducted by other universities and organizations. This week is Public Service Recognition Week, so before I hand it off, I'd like to thank everyone for your dedication. This is a disclaimer by CWEA. I'll just leave that up there for a moment. And let's continue with our moderator, Greg Kester. Greg is the Director of Renewable Resource Programs for CASA and the California Coordinator for Information about the Coronavirus in Wastewater. Greg is CASA's subject matter expert on emerging issues at the local, state, and federal level. Greg?
Thank you, Wendy, and welcome everyone. It's wonderful to have you here at our second webinar, addressing the potential and real impacts of COVID-19 to the wastewater sector. We remain in an unprecedented and unique circumstance and hope you are all safe and faring as best as is possible during these times. We continue to want to ensure safety for our workforce, especially those in collection and others who may be exposed to COVID-19 in wastewater prior to treatment. We're also interested in the potential of using wastewater-based epidemiology as another metric to assess shelter-in-place policies, especially given issues with widespread individual testing for COVID. We have assembled well-informed experts for today's panel to discuss worker safety, impacts of the pandemic on the wastewater sector, and wastewater surveillance as a quantifiable metric. We can't overstate our appreciation for them to take time and address us today. So welcome to everyone, and we can begin. And just as a reminder again, because we have so many attendees, we're not able to use the raised hand feature because of the size. So if you have questions, please type those into the Q&A section and use the chat function for comments. And then we will have a Q&A session at the end of all the presentations. And if we can start off, we'll have a couple of poll questions throughout the session. And the first one you can see here, and please respond here for what type of organization you work for. So it looks like the majority of you all work for municipalities, a combination of large, medium, and small, and obviously some others as well. So thank you all for joining us. Let me introduce our first speaker then to begin with Dr. Amy Kirby, who is an environmental microbiologist in the waterborne disease prevention branch at the Centers for Disease Control and Prevention. At CDC, Dr. Kirby studies antibiotic resistance, resistant bacteria, and natural and man-made water systems. She uses a combination of traditional culture-based methods and advanced molecular methods to assess the prevalence and dynamics of anti-resistant bacteria and anti-resistant genes in drinking water, wastewater, and recreational water, such as oceans, lakes, and pools. She is currently deployed to the COVID response team as part of the Community Mitigation Task Force, Water, Sanitation, and Hygiene team. And just as a disclaimer, the CDC wants to ensure that this call is not intended for media. Media can direct their questions for the CDC to media@cdc.gov. And with that, I'd like to turn it over to Dr. Kirby.
Great, thank you, Greg. And I really want to start by saying thank you to the organizers for allowing us to present today. I think this is really important information, and we always look forward to, one, engaging with our utility partners and getting this information out. Okay, so what we're going to talk about today, I'm going to give you a little update on the COVID pandemic and where we stand. I'm going to talk about our guidance for essential workers and how you can protect yourself and your staff. I'll do a little bit of background on sewage surveillance. I'm not going to go too deeply into that because we have a couple of other presenters that have actual data, which is great. So we want to have them talk about that. And we'll talk about wastewater risk assessment, and then I'll point you towards some of the CDC resources that might be of use to you and your staff. Okay, so where do we stand with the COVID-19 outbreak? So this started in China in late December, and the first US case was reported January 21st of this year. So the disease is called COVID-19. It's caused by a virus called called SARS-CoV-2. It's very closely related to the SARS virus, which caused the SARS outbreak in 2003. As of yesterday, we had 1,186,254 confirmed cases and 64,645 deaths. And we now have cases in all 50 states and 7 of the U.S. affiliated jurisdictions. And this link here will take you to the page that gives updates. It's updated every day at 3 o'clock with current case counts and distributions. So a little background on how it spreads. This virus is, in a lot of ways, a typical respiratory virus. So it's thought to spread mainly from person to person. And it's spread through respiratory droplets, which are sort of what you can see when you sneeze or cough. So they're fairly large. They tend to fall to the ground fairly quickly once they leave the person that's coughing or sneezing or talking. And so we think that the primary risk zone is within 6 feet of an ill person. So between people who are in close contact, so within that 6-foot barrier, and again, the respiratory droplets produced when you cough or sneeze or talk, those respiratory droplets land in the mouths or noses of people who are nearby or can be inhaled, and that's how they get sick. We also now have data suggesting that people without symptoms may be able to spread COVID-19, which is why we have talking in there as a way that these respiratory droplets are spread. And it's also important to note that we can get COVID-19 by touching contaminated surfaces. So those respiratory droplets might fall on a countertop that's nearby, and then someone can come along and touch the countertop, get the virus on their hands, and then touch their mouth, nose, or eyes and infect themselves that way. The symptoms have changed a bit in the past week, or at least what we consider to be characteristic symptoms of the disease. So cough, shortness of breath, and fever. Fever is greater than 100.4. But also chills, headache, muscle pain, sore throat. We're now recognizing that a loss of taste or smell, if that's a sudden loss of taste or smell, it often accompanies this disease, and repeated shaking with chills. If you think you might have COVID, you can go to this symptom self-checker, which is linked at the bottom of this page, or you can just Google CDC symptom self-checker, and it will go to a page where you can check off your symptoms, and it will tell you if that's consistent with COVID and whether or not you should seek medical care. As we all know, there's a wide range of illness that's reported here. It can be completely asymptomatic, very mild. Most people can recover at home, but it also causes very severe illness and can result in death. The incubation period is 2 to 14 days. So this is the period between when someone is infected and when they get sick. So very short, 2 days to up to a couple of weeks. And the complications, most commonly pneumonia, but that can lead to respiratory failure and multi-system organ failure. So how do you protect yourself? Really, what we're looking at as the best protections are basic hygiene. So avoid touching your eyes, nose, and mouth with unwashed hands. Avoid close contact with people when you're not at home. So, you know, you're already exposed to the people that you live with, but you don't need to be closely exposed to the people in the grocery store or the people that you work with. So try and keep that 6-foot barrier as much as you can. And that's what we call social distancing. You want to wash your hands often with soap and water for at least 20 seconds. So sing the happy birthday song twice. And the key times for washing your hands are, you know, before and after eating or preparing food, after you go to the bathroom, after you change a diaper, after you cough or sneeze, and after you've been out in public. So when you come home, you want to wash your hands. If you can't wash your hands with soap and water, an alcohol-based hand sanitizer will work as well, as long as it has at least 60% alcohol. And then cleaning and disinfecting frequently touched objects and surfaces is really important to protect against that transmission through a surface. And we really want to encourage people to focus on those frequently touched objects, particularly those that are touched by multiple people. So we're not worried about things that no one's touching, like a wall or a ceiling or a floor. We're really more concerned about the countertops, the doorknobs, the light switches, the remote controls, the things that multiple people are touching a lot. Other ways you can help prevent this, if you feel sick, please stay home, even if you think it's allergies or a cold. The symptoms for this are pretty non-specific and often look like other things, so just stay home when you are feeling sick. If you cough or sneeze, please cover it with a tissue and then throw the tissue away and wash your hands. If you don't have a tissue, you can cough or sneeze into your elbow so that you're not generating a lot of those respiratory droplets. We're encouraging people to wear cloth face coverings that should cover your nose and mouth and be snug against your face when you're out in public. So it's important to note that these cloth face coverings are not personal protective equipment. They are not meant to protect you, the wearer. They're meant to protect other people in case you are infected and you don't know it. It limits the amount of respiratory droplets that you're expelling and potentially infecting people around you. But having said that, cloth face coverings are not a substitute for social distancing. We really want, all of these methods are only reduce your risk some, and so the best thing you can do is take multiple steps. And so if each one reduces the risk some, collectively they will reduce the risk a lot. So we want you to wear cloth face covering in public, but still social distance as much as possible, still wash your hands, all of those things. And I should also note that cloth face coverings are not recommended for children under 2. If you do get sick, again, please stay home. Most people can recover at home. Stay away from people, even the people you live with, as much as possible. Wear a cloth face covering if you are around people. Again, the whole point of those cloth face coverings is to prevent you from infecting someone else. Cover your coughs and sneezes and wash your hands. Wash your hands frequently. Avoid sharing of those personal household items. So if you can limit that, don't handle the same remote, don't use the same phone. That's a really good thing to do. And clean and disinfect frequently touched objects and surfaces in your household so that you don't get the people you live with sick. If your symptoms get worse, so the things you should be looking for that are early warning signs are trouble breathing, a persistent pain or pressure in your chest, new confusion or inability to rouse, so that's really what your caregiver should be looking for, and bluish lips or your face starts to turn blue. If any of those things happen or you just feel like the symptoms are getting to where you can't handle them, please call your doctor or 911 if it's an emergency. If you're going to visit your doctor, please call ahead and tell them that you think you might have COVID so they know you're coming. If you call 911, tell the operator of your COVID status or if you think you might have COVID so that the EMTs can take appropriate precautions. And in both cases, put on a cloth face covering before help arrives so that you're protecting those emergency workers. If you are able to get through COVID at home without having to seek medical care, this is how you know when you can go back to work. So this is also important for employers, knowing when their employees can come back to work. So going from left to right, if you were tested and you had a positive COVID test, you can end your home isolation when you have no fever without a fever-reducing medicine, and your other symptoms have improved, and you've tested negative twice in a row, and those tests were at least 24 hours apart. If you did not have a COVID-19 test, then you want to have had no fever for at least 3 days without fever-reducing medicine, and your other symptoms have improved, and it's been 10 days since your symptoms began. If you had a COVID test but you were never symptomatic, so there's no fever or symptoms to improve, then you want it to have been 10 days since your positive test. And you've developed no symptoms in that time. So you were asymptomatic the whole time. So I see a question. Those are new symptoms that are specific to COVID-19. The new smell, loss of smell and taste, and the shaking with chills have recently been added to the list of COVID symptoms. Okay, a little bit about social distancing and face covering. These are really the best things we can do to prevent community spread. So again, that 6-foot barrier with people, try not to or avoid gathering in groups, stay out of crowded places and avoid mass gatherings. And if you have to go out in public, wear a cloth face covering, especially in situations where you may be near people, even transiently, like the grocery store, where you might pass someone in the aisle. A few face covering do's and don'ts. Do make sure you can breathe through it. We don't want to cause another problem. We're trying to protect from COVID. Do wear it when you go out in public. Make sure it covers both your nose and your mouth, because we know respiratory droplets are being generated from both. And wash your face covering after you use it, and wash your hands after you handle your face covering. Don't use face coverings on someone who's under 2, and also someone who is incapable of removing it if they have trouble breathing. And it's worth noting again that surgical masks are not a substitute for cloth face coverings. Those are PPE that it's important to reserve for healthcare workers. Okay, a little bit about our guidance for essential workers, and there's a lot more online. I'll have the link to this in the end, but I wanted to go through sort of the basics. So we're really putting a lot of stress on infection control for our essential workers, because we need to keep them healthy. So you want to avoid anything that would, oh, sorry, my phone is ringing. You want to avoid any thing that you would share near your mouth or nose, like headsets. You definitely don't want to share those with your coworkers. You want to increase cleaning of surfaces and objects frequently touched by multiple people. Consider pilot testing the use of face coverings at work. So we know that you're going to be around your coworkers, and cloth face coverings would be a great way to limit infection, but we want to make sure that they don't interfere with your work. Work with your maintenance staff to increase air exchanges in closed rooms as much as possible, because we know ventilation is going to help reduce those respiratory droplets. And encourage physical distancing among employees. So stagger your breaks, don't congregate, and don't share food or utensils. If you are exposed to COVID at work, do take your temperature before you come to work to see if you're spiking a fever. Wear a face covering at all times and practice social distancing. Don't stay at work. If you start feeling sick, please go home immediately. Again, don't share headsets and don't congregate with your coworkers. If a worker at your facility is exposed to COVID-19, you can take their temperature and assess symptoms prior to starting work, and we have examples of how to implement that on our website. You should send employees home immediately if they become sick during the day, so that they're not potentially exposing their coworkers. Again, test the use of face coverings, increase air exchanges, and increase cleaning of surfaces and objects frequently touched by multiple people. Okay, so let's talk a little bit about sewage surveillance. This has become a very hot topic, as I'm sure everyone knows. This is just a small selection of articles that have come out recently in New York Times, CNN, Politico, about the promise of sewage surveillance. So a little bit about what sewage surveillance is. This is not a new idea. People have been talking about it for enteric pathogens and using it for polio for many years. And so the goal here is essentially using sewage as a community stool sample. So instead of testing everyone in the community by testing their stool, let's just test sewage as a collection of everybody's stool, is the general idea. So measuring pathogens in sewage with the goal of estimating the prevalence of an infection in the community. And this has been successfully used for many years for polio surveillance. So some of the strengths and limitations, specifically for COVID-19, we think that sewage surveillance may provide an early indicator relative to our clinical indicators. So all of our clinical indicators are really based on people being in the hospital and seeking medical care. And so those lag for a few days up to potentially a couple of weeks from when people get infected. Sewage surveillance could be quicker than that, which would be really promising. It captures asymptomatic and mild cases, so even these people that don't know that they're infected, we could still see them in sewage surveillance. And importantly, it's not influenced by help-seeking behaviors. So it's not going to be influenced by people not going to the hospital because they don't have health care, or not going to the hospital because they're afraid of getting sick. We will capture them whether they go to the doctor or not. However, there's some important limitations that we should keep in mind. In order to be really useful, it needs to be near real time. So getting sewage samples and storing them for a while before testing doesn't really help you much. We need to have it be as close to real time as it can be. There's limited data on fecal shedding in this particular disease, which makes our model estimates a little imprecise. So we need more data there to improve our models. And one of the things that's also been really notable about this particular outbreak is we are having some rather extreme supply chain limitations for clinical testing. And the clinical supply chains overlap with our environmental testing supply chains. And so we need to be sure that when we start doing environmental testing, we're not adding additional stress to our clinical supply chains. So we need to approach this very carefully. One of the things that we really want people to recognize is that PCR detection of the virus, which is what we're using for sewage surveillance, does not mean that the virus in sewage is infectious. Those things are not automatically related. So what this graphic is a generic enveloped virus like SARS-CoV-2. So you see the genome, which for SARS-CoV-2 would be RNA. It's that red line on the inside. And then it's surrounded by a protein capsid, that green, roughly soccer ball looking shape. And then around that is a lipid envelope, which is lipids just like our cells. And then it has protein spikes in it, which are the orange spikes there. In order for a virus to be infectious, that whole virus particle needs to be intact. It needs all of those components in order to infect a cell and cause an infection and ultimately cause illness. However, PCR detection, which again is what we're using to detect the virus in sewage, only detects a fragment of the RNA. So those protein spikes could be damaged, the lipid envelope could be damaged, the capsid, the green capsid there can be damaged, and even the genome can be damaged. As long as the fragment that we're detecting is intact, we will get a positive PCR. So we should not interpret PCR detections as necessarily meaning that infectious virus is there. And we're going to talk more about infectious virus in just a minute, but I want to make that very clear that these two things are not equivalent. We expect PCR detection to be higher than infectious virus. Okay, so let's talk about the risk because that's where that automatically leads. So we don't know much about SARS-CoV-2 live virus in wastewater, but we do have data on SARS-1, the virus that caused the SARS outbreak in 2003. And so what you can see there, these are two tables from a paper that was published in 2005 by Wang et al. And so they took several different sewage samples and held them at either 20 degrees C, which is roughly room temperature, it's kind of cool room temperature, or 4 degrees C, so in a refrigerator, and asked how long they could detect SARS. And on the left side, this is roughly room temperature. You see they detected it up to 2 days, but then not after that. At refrigerator temperatures, however, they could detect it for 2 weeks, so out to 14 days. And this is something that we know is really common with these SARS viruses, is that they are highly impacted by temperature. They're much more stable in refrigerator temperatures than they are at room temperature. Whether the virus that's shed in feces is infectious or not is still unclear. There is limited data on that, but it's conflicting, unfortunately. So we don't really have a good answer there. We do expect that treatment methods and disinfection that's used in wastewater treatment and drinking water treatment for that matter to be effective against SARS-CoV-2. And importantly, we're not seeing epidemiological evidence of a higher infection rate in wastewater workers as we might expect if there was a risk there. So the recommendation is still for workers to use their standard PPE, but they should still engage in task-specific risk assessments as OSHA recommends for any sewage contact. We are conducting a study to ensure that those recommendations are correct. And so this study is in collaboration with the University of South Carolina. Dr. Sean Norman is leading it. And the two primary objectives are to evaluate the COVID-19 infection risk in wastewater workers, and they're comparing them to drinking water workers. So the idea there is that wastewater workers are potentially a higher risk category. How do they compare to drinking water workers that have a very similar job, but we think they're lower risk? And so they're comparing those two groups and looking for any evidence of excess risk in wastewater workers. And again, we think they're going to find none, but we want to be sure that's the case. And we're also assessing the impact of COVID-19 on antibiotic resistance. This study has 10 different sites, 10 plants in South Carolina, Texas, and California, and they're measuring the virus in influent bioaerosols and also throughout treatment to confirm that our treatment processes are effective at removing this virus. And we expect to have preliminary data in late May or early June for this. And then, as I promised, here's some of our CDC resources. This is a tiny, tiny selection of the things that we have on our website. I just wanted you to be aware of where these specific things were. So the top link is our landing page for all COVID-19 information, so you can go there and explore. I've also linked our guidance for essential workers, which has more details there. We do have a page that's really an FAQ of COVID-19 and water. We have a lot of communication resources, so if you want posters to encourage your staff to practice social distancing or wear face coverings or wash their hands, we have posters and social media messages available there for you to download. We also have information on hand washing, and then our cleaning and disinfection guidance has lots of details there as well. And with that, I will turn it over to the next speaker, and I look forward to answering your questions. Uh-oh. I may have accidentally hit that link.
It doesn't look like it. Thank you, Amy. That was great. And again, just for folks, we will be having the Q&A session at the end of all of the presentations. And if you have questions, please type those in the Q&A box on the bottom of your screen. And with that, I'd like to introduce our next speaker, Dr. Chuck Gerba, who is a professor of epidemiology and biostatistics in the Department of Environmental Science at the University of Arizona. He has authored over 500 journal articles, books, and has been featured on numerous television programs and magazines. Dr. Gerba has an international reputation for his methodologies for pathogen detection in water, wastewater, and food, pathogen occurrence in households, and risk assessment. With that, I'm very pleased to turn it over to Dr. Gerba. Chuck?
Hey, thanks a lot. Good to talk to you today. I'm going to be representing actually the group here at the West Center located near Pima County's wastewater reclamation site. We've been involved in monitoring viruses in wastewater and biosolids for the last 7 years at this plant, getting an idea of largely plant efficiency and treatment in that. Let me go to the next slide, just to show what a coronavirus is, again, from the standpoint of looking at its ability to survive in the environment. The lipid status of the virus actually makes it much more susceptible to disinfectants and to some degree limits its survival in water in the environment. Viruses without a lipid, such as hepatitis A, survive much longer in the environment than lipid-containing viruses. So they're not really known as really being transmitted by the water route. Just to give you an idea of the different types of human coronaviruses, there are two that are associated with the common cold, 229E and OC43. These cause estimated up to about 1/3 of the common colds in the United States. And then, of course, you have the SARS, MERS, and the SARS-CoV-2 agent. Just to notice the difference between the diseases, as they're called. COVID-19 is disease, SARS-CoV-2 is actually referred to as the virus. The next slide, again, reiterates the survival of the coronaviruses in water. We did a study a number of years ago looking at a couple of different types of coronaviruses in that, and they're fairly unstable in water, only lasting about 2 or 3 days in wastewater, primary effluent, tap water, and that, compared to PV1 down here, which is poliovirus type 1, where the virus dies off really fast. The coronaviruses, the polioviruses actually survive for a much longer time. So this virus is not really very adapted to long-term survival in wastewater, except in water, except at low temperatures. Some background on this, it was already mentioned by Amy, is the infectious virus has been detected in patients. In 2 studies, they were found to be infective. In 2, they were not. A recent study found that they might be inactivated in the colon by fluids within the colon. So it's still open to question whether there's infectious virus present. Recently, there was just a report today of infectious virus being excreted in the urine. Infectious viruses are known to be excreted in the urine, but I think these types of studies need a lot more investigation before we have a real idea of how long these viruses may survive in the environment or even be present in infectious form in feces. Now, they are present in infectious form in mucus and saliva. Now, the virus has been shown it will survive for 2 or 3 days on plastic and stainless steel surfaces, less time on copper surfaces. Copper surfaces are known to be antiviral, is probably the reason. Less on cardboard surfaces, probably because that reduces the amount of moisture available, which is important in the survival of the viruses. They've been reported to survive 3 hours in one study, 16 hours in a more recent study, so they seem to be at least fairly stable in the environment. Now, as emphasized, there's been no evidence for transmission by feces or inanimate surfaces, which we call fomites, or really confirmation of any infectious virus in sewage. How the virus can be excreted in patients up to 5 weeks after infection, and the concentration can be fairly high per gram of feces. Now, when you think of the average person, bowel movement of about 150 grams in the United States, you can see where you can be excreting a large amount of virus, although it's, again, not known whether it's infectious or not. Again, this gives a survival on the surfaces in that of this particular virus. I just want to talk about like sample collection and some of the aspects of sample collection and analysis of wastewater samples. We've been doing that here in Tucson, like I say, for about the last 7 years. We've increased our frequency, and we've been collaborating with a number of utilities and other groups on the occurrence of the virus in wastewater. For raw sewage, we usually collect 500 to 1 liter samples. For treated wastewaters, we collect anywhere from 2 liters to up to 100 liters, but usually only 100 to 250 mLs is processed currently. We do spike all our samples, split them, and we add a control of coronavirus 229E to determine the efficiency of the virus, the concentration method for it, because we know the concentration method's not 100% efficient, and a lot is not known on the efficiency of the ability to concentrate coronavirus in wastewater. We also archive all our samples and keep them stored in that for future use, so we can go back and look at if we want to analyze these samples in more detail in the future, or to look at different markers for the virus, or to look for infectious viruses. Now, there's no general accepted method for lipid-containing viruses currently, although there's efforts by the Water Research Foundation to bring the groups together that are starting to come up with methods. Basically, 4 methods are being used. We use a process of centrifugation, filtration, ultrafiltration, but others use membrane filter, adsorption, elution, a very traditional method, filtration, ultrafiltration, and positively charged filter adsorption is used. A fiberglass filter are used in Europe. The next slide, it gives you an idea of what we do. We just take a wastewater sample, centrifuge out the solids. We oftentimes test these solids too for the presence of the virus. They are present in the solids, by the way. Pass through a series of filters to remove the bacteria, and then we use centricons. And then we, as mentioned, we use molecular methods, RPC, not a viability method currently. Basically, what we've been doing here at the University of Arizona is after we do the RTCP, if it's present, we're saving these samples to put in cell culture. We gained access this week to a biosafety level 3 laboratory, which allows us to grow the virus if it's present. And we're going to be starting testing these samples to see if we can determine if any of this virus is infectious. And then that can later be confirmed by RT-PCR that the virus actually grew. So far, results have been a lot of investigators around the world, and on viruses by molecular methods have been detected in Europe and several countries and several locations in the United States. Most of the results have really been presence absence, since efficiency methods have not been reported in a lot of these studies, or weren't done, or they were done with non-lipid containing viruses as the virus to assess concentration. Spain recently reported 100,000 gene copies per liter in untreated wastewater, and we've seen that recently in samples from the United States too. Results indicate that 2 to 3 clinical cases per 100,000 people can be detected by wastewater testing. So that's one of the interests in the public health agencies is you can detect low numbers of cases particularly. But as been pointed out by Amy, both asymptomatic and symptomatic cases can be detected by the excretion of the virus. Unfortunately, a lot of efficiency methodology is not available, so what is one method's good or better than another is not known. And to get a precise idea on the number of viruses in the wastewater is difficult to assess at the current time. Now in Tucson, we first detected the SARS-CoV-2 beginning March 18th, and some of our samples have as much as 100,000 gene copies per liter. No virus detected after our Barden flow process here in Tucson, indicating at least a 90% reduction. Unfortunately, we haven't had time to assay a lot of the treatment process samples. We've been focusing on monitoring the raw wastewater at the present time. We hope to get a better number on that. We did detect virus in the primary settled solids. It's known that lipid viruses prefer to be associated with the solids. Levels of viruses in the wastewater have decreased in Tucson since the stay-at-home orders went into effect, and are below several locations, both in California and some of our samples, other locations in the United States that have been reported or we have observed in our own sampling. So the stay-at-home orders seem to have already a detectable impact on the concentrations in the occurrence of the COVID-19 virus. Now, what we've done, since we do efficiency, we've noticed concentration efficiencies vary greatly across the United States, anywhere from 0.1 to 50%. Maybe it's some high fiber diets in some parts of the United States. I don't know, but there's a lot of variability, which we have to take into account. And that's one of the reasons we do an efficiency control. The other thing that we're doing is a lot of work on antiviral cloth materials and antimicrobial coatings on surfaces, because we see that a way as decreasing the exposure to the agent. And we've had success with cloth materials recently that can reduce coronaviruses by 99% within 10 minutes. We see this as another useful purpose for controlling exposure to workers, in that if we develop and can make available antiviral clothing or antiviral surfaces in the future. What we're doing currently, our efforts, is we're looking at removal by treatment processes. We're looking at contact time. for chloramines. Chloramines are used locally for disinfecting wastewater, and there's really no data available on the CT time or contact time necessary for chloramines to be effective against coronaviruses, and we're currently doing that. We're doing bioaerosol detection at different sewer operations using large volume samplers and also samplers carried by the wastewater workers. There are devices available now that can concentrate viruses out of 250 liters per minute now, and we're looking at that currently. And then we're looking at continuously acting disinfectants for clothing and hard surfaces. Some of these are now available in spray. You can spray surfaces now that'll leave an antiviral coating that we found work quite well against coronaviruses. And I could leave it to the next speaker then. If that's all my slides.
Thanks very much, Chuck. And I believe we have another poll question coming up at this point. Has your agency sent influent wastewater samples to a lab for analysis of the SARS-CoV-2 virus or RNA strands? Okay, so in the poll results, a good amount, 21% have sent samples for analysis, while 32% have not. Some are unsure. Thank you very much. And with that, let's go to our next speaker. Dr. Rasha Maal-Bared is a senior microbiologist at EPCOR Water Services Incorporated in Edmonton, Canada. She runs both the drinking water and wastewater microbiology laboratories and conducts research related to optimization of water monitoring, treatment, and distribution. She's an environmental microbiologist whose work focuses on protecting public health by understanding waterborne pathogen ecology, survival, and transmission in both natural and engineered environments. She currently serves as the chair of WEF's Waterborne Infectious Disease Outbreaks Control Subcommittee, known as WIDOC. With that, let's welcome Dr. Maal-Bared. Rasha?
Thank you very much, Greg. So as you can see from my title today, I'm going to do things slightly different than last time. Last time I just gave you a scientific update, where the literature is at, and all the new highlights popping up. Today I was asked to tell you a bit about worker safety. So let's see what we can do here. Some of you may have already seen our WEF recommendations. These were published back in February, and they really highlighted 3 areas where we wanted to focus our attention. The people area, which focused on our employees and our workers, and the messaging there was pretty clear and very, very straightforward. We wanted people to stay informed and not to panic. We wanted managers and utility folk to really communicate why we're making the decisions we're making. And most importantly, we wanted people to encourage compliance with PPE and with good hygiene standards. There were also a lot of recommendations made on the process side, which pretty much all went back to us saying, we want you to continue business as usual. And that was partially based on our assessment, which aligned with CDC and with the World Health Organization at the time, where we all felt that our current disinfection practices and our wastewater treatment should be sufficient to control coronaviruses and specifically COVID-19 virus in wastewater. We also felt that many of the monitoring parameters for our process control would tell us a little bit about our ability to remove this virus. So whether it's free chlorine or your indicator bacteria or your UVT, all of this gives us a bit of information. Supply chains had to adapt very quickly. And on the plant side of things, we pretty much got many of our constituency to focus on administrative controls and engineering controls and looking at the systems that control protecting our workers. This was all based on 2 pieces of information: what we knew about healthcare and what we knew from wastewater treatment itself. So from healthcare, you've all seen this sort of hierarchy of organisms that we know are resistant to susceptible on the disinfection scale. So as you look at these prions, bacterial spores, right at the top of this list are actually very resistant to disinfection and environmental decay. While when you look right at the bottom, enveloped viruses, which COVID-19 virus actually belongs to, is not. It is very susceptible. So when you take that information and you superimpose it on what we know about water and wastewater treatment, it actually gives you some very interesting information. So if you're looking at this diagram starting on the far left here with collection systems, as Amy and as Dr. Gerba have already pointed out, we don't really know very much about the survival of infective virus right now in feces. We know even less about its survival in wastewater. We have a lot of RNA data, but RNA data does not tell you anything about infectivity. So many experts, CDC included, still believe that wastewater is not a significant route of transmission. So if you move on to our process design at our wastewater treatment plants, you already know that when we've designed our plants, they are designed to really handle those non-enveloped enteric viruses, which are far more resistant, if not equally resistant, to the coronaviruses we're trying to remove right now. If you move on to the next step, the multi-barrier approach, well, that's where every step has its role, whether it's treatment or retention or sedimentation and coagulation. Every step does a bit of removal. Sometimes it's higher than what we think, sometimes it's lower than what we think, but it's really that cumulative impact that we're looking for. Then we have that disinfection stage, and that's highlighted because really that's the stage most of us focus on and understand to some extent, with lots of gaps, obviously, but conventional treatments and UV irradiation are expected to inactivate coronaviruses. And there's been multiple statements and studies and in papers that have suggested that it's actually the large size of the single-stranded RNA of coronavirus that makes it susceptible to this UV irradiation. And then finally, as I've mentioned, we monitor a lot of parameters as part of our process control. So whether it's E. coli or UVT or TSS, that all tells you a little bit about process efficacy. And we do know that chlorination, oxidation treatments, and UV irradiation do work. So this should give you a bit of confidence in the work we do on a daily basis. The question that has come up more often, though, these days has been related to worker safety. And really, when we assess worker safety, it's not as straightforward as us just monitoring COVID-19 virus in secondary or tertiary effluent and saying you are safe. Often what we have to do is a fairly elaborate process. So some of you who may look through the literature may see that we've actually done what is called a quantitative microbial risk assessment to actually look at whether or not our workers are safe. So a quantitative microbial risk assessment is a 4-stage process. It starts with a basic question: is the hazard there and at what concentration? So in this case, it's COVID-19 virus. Is it there and is it infective in our wastewater, in our collection system, in our plumbing system, and so on? The next stage looks at your worker, and it tries to ask the question, if my worker is there at the screens, at the grid tanks, how often are they exposed? How long are they exposed? And what is the route of exposure? Is it inhalation? Is it ingestion? Is it touching the eyes? So on, right? The third stage would be what we call the dose response assessment, where you would try to basically say, okay, well, this is how much I have and how much contact you have. Is that likely to result in an adverse, a bad outcome, right? And how often is that going to happen? And then, because you're doing that on such a small scale, you have to replicate this at the population size. So in this case, your worker population at your plant. Is there overall risk of infection of COVID if your workers are handling primary or biosalts or so on? So I can tell you right now, this would be problematic for us to do because we don't have a lot of data, as Dr. Gerba had mentioned, as Amy had mentioned. I noticed in the Q&A, a few of you have expressed your frustration with the we don't know, but we have to be honest about what we don't know and what we do know. So what can I tell you about what I know about our wastewater systems at our plants, we do know that we have yet to find evidence of survival of infective COVID in feces. Despite the 2 studies that we've referred to, no one's been able to replicate those 2 studies. Now, there has been infective virus found now recently today in urine, and that changes things a bit. We have not found it in collection systems yet. We will find RNA. I have no doubt about that. It's just a matter of time, especially now that I know that Dr. Gerba is working on it. We haven't found it in wastewater yet, and we haven't found it in plant bioaerosols yet, right? Now, we know, again, if it's in urine, once this result is confirmed, we do know it's in respiratory secretions and in saliva. So it is probably going to reach our plants at concentrations. Will it be infective or not? We won't be able to know that. But what we do know is that right now there are many efforts to try and assess what the relative risk of exposure to wastewater is. We continue to say that we don't think it's a significant route of transmission because there's no evidence to suggest that it is, but we just don't know. So what we rely on is qualitative assessments, our expert opinions, and precautionary principles. WEF has just realized there's a major knowledge gap when it comes to bioaerosols in general at wastewater treatment plants. And it has established a blue ribbon panel to look at bioaerosol exposures and what we can tell our workers about respiratory protection around the screens, around headworks, around the bioreactors, and so on. But going back to my concept about precautionary principle, we need to be honest. We're not dealing with clean water here. Wastewater is nasty. It is full of pathogens, many of which are more resistant or pathogenic, some of which cause chronic illness in the long run. So why would we pretend like we don't know what to do? We have protections in place, and those protections, the requirement for us to protect ourselves and our workers is why we are able to state that we have a system, we have something we can rely on. So this actual figure, this graphic, was created by the WEDOC committee at WEF as part of an Ebola article that was published back in January before things got crazy with COVID. But it was actually constructed with the help of Christopher Brown from OSHA. And he very much highlighted the fact that there is a hierarchy. We know the hierarchy. You start with your engineering controls, your screens, your sprays, where you limit the contact of your worker with that wastewater matrix. Then you have your administrative controls and safe work practices, where we talk about don't touch your face. If you have open sores, cover them. Don't go home in dirty clothes. If there's vaccines that are effective and that are assessed by a risk assessment and that your workers need, make sure you administer them or have a program in place for that. And then there's the protective equipment. So your goggles, your rubber boots, the liquid repellent coveralls and gloves and so on, right? Face masks, so shields. I think we've all talked about shields, especially to protect our workers from splashes. Now, when it comes to respirators, N95s, N100s, full respirators, those are things we don't know much about and we're hoping to gain more knowledge about through this WEF Blue Ribbon Committee. So because these hierarchies of controls are already in place, of course, when you look on the OSHA website, you can see right here that municipal waste, recyclable materials, and wastewater treatment are all under the lowest category of risk here. Now, you're probably wondering, why is medium then highlighted? Well, that is when you're handling patient waste from healthcare facilities where there are suspected or confirmed positive cases. So in our case, again, we know there is many pathogens in our wastewater, and so we are already protected by the standards in place. There's been a lot of questions about residuals and biosalts. So let me highlight to you the work that is being led by Carrie Brissolara at LSU, and that many people in this call included, like Greg and Dr. Gerba, have been involved in. So when we talk about residuals, we're really talking about the 4 main classes. So if you look at the red banner in this table right at the top, you have raw human feces, raw municipal sludge, Class B biosalts, and then your Class A biosolids. So what we know about these is for all these 4 categories, The relevant information is in that first red box. We know the virus RNA is shed in feces for a long period of time, even by asymptomatic individuals. So that's not really a surprise, right? We know infective virus has still to be isolated and quantified, despite the 2 studies that came from the China CDC. But we certainly know that other coronaviruses have been isolated from feces in the past. So SARS has been, OC43 has been, and 22E9 has been as well. So is it unlikely that it's there in an infective? Let's hope so. But for now, even if it was there, we can assume that the highest risk of infection is going to be related to exposure to fresh feces, right? So that's the bathroom, the plumbing system, the collection system. And this is, of course, that becomes more extreme if you have wash challenges. So hygiene and sanitation are challenged. Think of sub-Saharan Africa. Thank goodness, in most places, we don't have to deal with that, but those definitely add an extra layer of complexity. So if you look at raw municipal sludge to Class A biosolids now, again, you've heard from the previous speakers that wastewater does contain RNA from the virus. So we can't just assume it's not there. We know it's in respiratory secretions. We know it might be in urine now. So let's assume it is actually there. But what do we also know? That raw municipal sludge and Class B biosolids obviously contain coronaviruses. This isn't surprising. But we also know that wastewater treatment processes control the virus fairly well. We don't expect it to be more resilient than many of the pathogens there that have been tested for. And we certainly in Class A biosolids wouldn't expect it to be more resistant than our surrogate, which is a non-enveloped in that case, right? So we can certainly say what you have here is a decreasing risk gradient as you go from raw human feces to Class A biosolids. And since with Class A biosolids, we really wouldn't expect virus survival, you can certainly assume that it is safe to handle. So what we're trying to say here is, we know that there's no epidemiological evidence right now to link sludge or biosolids to risk of COVID infection. We have no evidence to support that the transmission is happening through wastewater systems or biosolids. And there's no evidence to establish that the presence of the infectious virus in feces or sewage or biosolids at the moment. I keep saying at the moment because the science is changing every day. And as I mentioned, there are many pathogens in Class B biosolids or in municipal sludges that we would be concerned about. So really what we're asking for is vigilance. You need to apply all good hygiene, administrative, engineering control, your PPE practices, your worker safety practices, all that has to be in place, especially when you're handling the untreated, the raw feces, or the Class B biosolids. Now, those of you who are familiar with Class B biosolids, we already have good protections in place. The protections in this case here address the personal protective equipment. So the choices of equipment, whether it's goggles, face shields, respirators, or coveralls, in some cases, it actually asks the employer to work directly with your worker to determine the risk associated with duties and tasks that your worker does. And if respirators are needed based on risk assessments at your workplace, then fit testing and training may be required as well. On the engineering side of things, we do expect people to offer hygiene stations if you have workers handling Class B biosolids or anything more contaminated than that. And for those of us who work in cabs, in vehicles, in tractors, cleanup of those areas, again, these frequently touched surfaces is important, whether you're worried about COVID-19 or any other pathogen. Finally, training should be frequent, it should be routine, it should cover everything from hand washing to PPE. And of course, you should train your workers on how to recognize potential work-related illnesses. Finally, when it comes to vaccinations, look up the CDC site. The tetanus and diphtheria vaccinations are supposed to be up to date. Some plants still give Hep A vaccinations, my plant included. It just has to do with your work tasks. You may have seen this. We have made it freely available on the WEF website. It has an outline of all the protective practices. Please, if you go on WEF, feel free to use it, feel free to print it. It is absolutely ours, and we want you to use it if it helps you protect your workers. And if you want to hear more about wastewater treatment, we do have a webcast coming up tomorrow that Dr. Gerba is participating in, that now Comunicata from LACSD is going to be moderating, and where we're going to talk about wastewater treatment systems and viral management. Thank you very much.
Thank you, Rasha, very much. And I believe we have another poll question now. What are the biggest challenges your agency is now facing due to the COVID-19 crisis? If you could, mark all that apply. And budget shortfalls, obtaining sufficient PPE equipment, the adjustment to remote working and video, certainly a big one, maintaining adequate staffing levels. So that's interesting about the PPE equipment difficulties. Okay, well, thank you very much. And let me introduce our final speaker, after which we will have the questions and answers. Proud to introduce Eileen White, who's a civil engineer and currently the director of wastewater for the East Bay Municipal Utility District in Oakland, which supplies water to approximately 1.4 million people and wastewater services to about 670,000 people. Eileen has more than 20 years of engineering experience in the wastewater, water, and power industries. As the director of wastewater, she's responsible for leading the wastewater department, which includes planning, organizing, and leading the engineering, operations, and maintenance of the wastewater system to ensure efficient operations that meet all regulations. And with that, pleased to introduce Eileen.
Great, thank you, Greg, and thank you, everyone. Let's see if I can advance this. I'm not sure. I got the wrong slide. Let me scroll down. Let's go here and Zoom slideshow. Okay, thank you so much. So when I last briefed everyone on April 1st, I was bringing one utility's perspective on how we were adapting in the wake of the coronavirus. Today, I want to give you some updates as we now transition back to this new normal and what will it look like when this shelter in place is gradually lifted. I think most of you know that EBMUD is located in Oakland, California. And we provide wastewater service to 700,000 customers, and we have about 2,000 employees. In today's presentation, I want to give you an update since I last briefed you about a month ago. I want to talk about our reconstitution plan, which is actually the emergency preparedness term for really a transition plan. And then I want to talk about the fiscal impacts. So to do a quick recap of last time, when the pandemic broke out, we quickly restored water service to ensure that all our customers could maintain good sanitation practices. We began issuing payment extensions, and our IT department quickly mobilized to get 1,000 employees telecommuting. For the employees that couldn't telecommute, we had to make sure that they were always safe at work. We secured additional parking, so to make sure people didn't have to take public transit. We implemented additional cleaning and implemented a number of measures to make sure that our employees would be safe and can observe the 6-foot social distancing guidelines per the Centers for Disease Control. So these measures that we've been taking since our last webinar on April 1st have been working. You can see here that the Bay Area and California have been flattened the curve. Compare the two bars highlighted to see our progress. So we've developed a symptoms checklist. So employees that must fill out each and every time before they report to work. So every day before I go to work, I fill this out and I submit to my supervisor that I've completed the checklist and I've checked no to all items on the checklist. and then employees can report to work. And the benefit of this is, one, to make sure everyone who's reporting to work is safe, but it also creates a record of who was in what facility in case an employee does test positive for COVID-19, and then we can follow up. Also, since I last briefed you about a month ago, we've implemented testing for our essential operators. So our operations staff, our key maintenance staff, and our lab staff are now getting tested every 2 weeks for COVID-19. We've also been monitoring the supply chains to make sure we can get the chemicals to continue to treat our wastewater. And to date, we have not had any impacts on the supply chains, with the exception of making hand sanitizer. So we've had a big need for hand sanitizers to keep our employees safe, especially those in the field. And we've had difficulty getting hand sanitizer. So what did we do? Our own lab has taken on the new role of producing hand sanitizers. So you can see these bottles here, and now they're distributed to employees who can now all have their own bottle of hand sanitizer while they're out in the field or doing their various jobs. And now, while we've been in this new mode where about half of EBMUD employees are now telecommuting and the others are out at the various treatment plants and pumping plants, in order to make sure that we continue to communicate with our employees, which can be very isolating during these times, we've implemented these town hall meetings. And I've had several of them to date, and they've been very effective in bringing employees together. In fact, I had another one yesterday. I invite all the employees in the department. It's optional, and then people can sign on to it. And basically, I give a quick update, thank everyone for their great work and their innovative ideas to continue to do our work safely. And then we open it up, and it provides a forum for them to ask questions and answers. As previous speakers said, the information changes so quickly that it's a great way to keep all our employees engaged with the latest changes in information, and also a chance for them to talk to other employees. And as I mentioned, the news keeps changing regularly. Well, last week on April 29th, there was a revised shelter-in-place order issued by Governor Newsom, and that's changed things. It now allows for all construction to start. So starting this past Monday, all our construction jobs that had stopped with our contractors that we had temporarily suspended have now resumed. Per the appendix B1 and B2 of this shelter-in-place order that was issued last week, we have to implement a number of strategies with our contractors to make sure their workers are safe. So we're making sure that our contractors are following all the requirements in these new shelter-in-place orders. And so this came out just last week on April 29th. And then just yesterday, the governor issued another executive order basically saying that he's deferring to the county health departments to make the decisions on lifting the shelter-in-place orders. And I should be careful about using the word lifting. I think we've heard the word. It's not like a light switch you turn on and off. It's more like a dimming switch. And so we'll be slowly relaxing them. And then tomorrow, the governor is supposed to have another announcement, another executive order, further relaxing the shelter-in-place order for California. And then we've also been trying to provide information to our staff about childcare for essential workers so that they know about the website and the information that is out there. Because with schools closed, that's another challenge for everyone. And then I want to kind of talk about something we've talked about earlier today. One problem we have that can basically be summarized in the two pie charts. First, we have a severe lack of testing for people who are showing symptoms. To date, less than 1% of California's population has been tested. Second, if people are showing symptoms, you can't even get tested. So what are we going to do about the 25% of people who get infected but are asymptomatic? Well, as people have brought up earlier today, our solution lies within wastewater. Coronavirus can be detected in wastewater not only as the infection develops, but also for several weeks after showing symptoms. So as people flush their waste and it enters the systems, the presence of coronavirus in wastewater, referred to as the sewage signal, presents a remarkable opportunity for us to track the spread of the virus throughout the community over time and spatially. In other words, we can sample the influence of the wastewater treatment plant for the entire community, or we can go to particular areas within the boundaries of the wastewater system. So EBMUD has been collaborating with a number of partners throughout the country. We've been very fortunate to partner with the University of South Carolina and Dr. Sean Norman that Dr. Amy Kirby referred to before. And we're working with them, one, to understand the potential exposure to our wastewater operators as they do their daily job. And then we're also working with them on this testing of the wastewater to understand the presence of coronavirus in the community. We're also working with UC Berkeley, Stanford. We've been discussing with the Arizona and with a private firm out of Boston. And so today, it's really interesting since we've sent samples to all these various universities. What we're going to do is kind of do a method comparison study to see, we have all these universities that have gotten our same samples and what do their results look like. Because we're all working so quickly, it's been difficult to do a sophisticated comparison study, but we hope to have data at the end of the month. And in fact, Stanford has data from 10 different Bay Area utilities and then from other utilities throughout the country. And when they get their results at the end of the month, we'll be able to use that information to see how it reflects the coronavirus growing in the community as we see it growing in the wastewater. And I think that's going to be a really useful tool as we continue knowing there's no vaccine for at least 18 months. So basically, the sewage will signal the spread of the virus at the population level, not the individual level. And as a result, the potential impact of sewage signal is much larger than that of the conventional testing. So how can we use this? Well, once that we've got the data at the end of the month and we see the correlation, as the previous speaker says, we don't really care so much about what was happening in March or early April, but if we see that there's that correlation, then it's useful, and then we can really take the data and then start using it in real time, and we can bridge the testing gap, we can monitor trends in real time, and we can initiate responses when necessary. This monitoring can help provide public health and medical professionals with a leading indicator of anticipated infection dynamics versus the lagging indicator of case counts. It can assess in targeting early population testing and focus on the appropriate public health measures such as quarantine or overall supply and resource distribution to enable the state's response system to be more efficient. So what we're doing is we're starting small with EBMUD. We're seeing what we can learn from this, and then we want to progressively expand this to the Bay Area, then to the entire state, and then use this as a model throughout the country, because we know COVID-19 is probably here for at least 18 more months. And so how this would work is, I just kind of walk through a little example, is that here it is at the results you might get at the state level. So during week 1, Northern and Southern California, as you can see on the far left, they have similar sewage signals. Then you can say, well, in Southern California, they get a heat wave and everyone heads to the beach spreading the virus. By week 2, the sewage signal detects a larger spread in Orange County, while the Bay Area sees continued improvement. At that point, you can send the Bay Area resources down south. Perhaps by week 3, the virus is spread throughout Southern California and the whole region needs to go back into shelter in place. So this is the vision on how we see this data would be used. And I'm happy to report that we've been talking with the Centers for Disease Control, and we'll be sharing our information with them. We're talking with the county health departments, and I've been talking with the largest healthcare provider in California, and they're very excited for me to share the results at the end of the month, because they see how the results from the Bay Area could really be very useful in expanding this throughout the entire state. So they're very excited and see this as a useful tool. So the next question is, how can we get creative and collaborate to find funding for this great initiative and tool? And so we've been pursuing state and federal funding, and funding's a little bit of a challenge. You know, EBMUD pays its bill through our ratepayer dollars, and our rates are set by the CASA service for our wastewater treatment. Even though wastewater treatment is inherently linked to public health, we legally can't use ratepayer dollars to do sampling all over the state. So we've been creative in asking how we can find funding. We've been trying to get state and federal funding. We haven't been successful. So I've recently pitched it privately, and I did get word this morning that at least we've made the short list for potential funding, but you know, I'm cautiously optimistic. But if we can get funding, we could really spread this through the, you know, make this as a model for the entire state and then replicate it throughout the country. So more to follow on this. And then I'd just like to kind of take you back to our timeline. You know, we're in this quote, shelter in place, pretty much they're saying through May, even though certain things have been lifted. And I kind of want to talk to you about where we are now, getting ready for the quote, reconstitution or transitioning employees back to work. And it will be a new normal for those who have been telecommuting. It's not coming back to things the way they used to be. And then a lot of you probably heard in the governor's previous discussions about his 6 indicators, and he really wants to return people back to work. He wants to have testing and contact tracing done. He wants the ability to prevent infection in people who are at risk for more severe COVID-19. He wants the ability of hospital and health systems to handle surges. He wants to be able for the schools and businesses to support physical distancing. And then he wants to be able to determine when to reinstitute certain measures, such as stay-at-home orders. So those are his 6 criteria that he set out a couple weeks ago. But as I said, he's supposed to have another executive order tomorrow that is supposedly going to relax some of the shelter-in-place orders. So since we don't have a vaccine, it is possible that a second wave is also going to hit us this winter. So we have a short window over the summer and fall to prepare. So right now we're kind of in the response category of the emergency response cycle. And what we want to do is we want to synthesize the lessons learned and quickly move on to the recovery, mitigation, and preparedness stage. So just some of the things we're doing. What we're doing is we're setting up strategies. We know our employees aren't going to want to come back on mass transit. For those of you who are familiar with the Bay Area and BART, you're lucky if the person standing next to you in normal operations isn't touching you, and that's not going to be acceptable. So we're really looking to try to maximize parking for our employees, knowing that they're not going to want to take public transportation as they come back from telecommuting. We also want to make sure we've executed strategies so that there's social distancing in the office. So in order to do that, we're making sure certain cubicles will not be accessible, or we'll have certain employees come back Monday and Wednesday, and maybe the person in the cubicle adjacent to them will be not telecommuting on those days, and then we'll be coming to the office on Tuesdays and Thursdays. So we'll make sure we're implementing strategies to ensure that social distancing is followed. We're also going to be increasing the height of the cubicle walls with plexiglass to ensure the safety of our employees. And then things are going to be different at the water cooler. There will no longer be people standing there talking close to each other. As much as we enjoy the dialogue and the sharing of information, people are going to have to be 6 feet apart when they're talking, and they're going to have masks on. And then, as I mentioned before, we've rented trailers at our plant, and those trailers are going to be used for our maintenance staff, so that they have areas where they won't all be in the same areas at the same time. So they'll have more working areas. And we've also rented trailers and set up computers and operation screens, so it can be, we'll limit the number of people in our control room by having additional trailers. And then, as I mentioned before, the social distancing in the lab is that people have gone from a 5-day-a-week lab to 7 days a week. And actually a lot of the employees like it, as they're still dealing with childcare issues. So as long as it's being successful and our employees are embracing it, I see no reason to change that, as people are still continuing to deal with childcare issues. So we're going to continue to have the 7-day lab, which will allow the people to have social distancing. And then where it's going to get a little more complicated is social distancing in the field. So one, all our workers will have to have masks on, and wherever possible, we want our employees to be 6 feet apart. We do recognize that there's going to be certain construction and certain things that need to get accomplished that will require less than 6 foot social distancing. So we'll want to make sure that our employees have soap, water, and hand sanitizers as they work in the field, and that they have masks on to ensure their safety. And then we're going to continue to allow telecommuting, but I think we're going to want to slowly but surely over time wind it back down from maybe people being 5 days a week to coming back 1 day a week, 2 days, because we do recognize there is inefficiencies with telecommuting, but we also want to embrace it as we want to keep our employees healthy, and we also understand that it's a difficult time with schools and daycares closed. And then I want to talk briefly about the fiscal impacts. We're very lucky that, fiscal year 20, the economy was a boom, and really COVID-19 did not really start to impact us until March. And so for fiscal year 20, we're going to end our finances looking okay. However, there's a lot of uncertainty as we go into fiscal year 21, thinking that COVID-19 will probably be something we're going to have to deal with throughout the next fiscal year. So some of the fiscal impacts is, we know there's a service area economic impacts. We know the unemployment rate continues to rise each day. We expect lower water demand, in particular for our commercial and industrial customers. We're expecting increased need for customer assistance. There's going to be decreased development, so we're not going to get the system capacity charges that we had estimated for next fiscal year. There's going to be increased delinquencies and bills, and we may have to partially suspend some capital projects or defer them to a later date. And then I just wanted to share with you, this table here shows data from the National League of Cities and the U.S. Conference of Mayors. And basically it shows agencies of all sizes. They're projecting that there will be some furloughs and layoffs, anywhere from 26% of the agencies to up to 59% of agencies will have some level of furloughs and layoffs. And so it's very sobering, but it just makes us realize that we're really in not only a health emergency, but also in an economic downturn, and that there's real impacts to businesses, to our employees, and to everyone. And that's just something we need to take into account in how we deal with our customers who can't pay their bills, and something we just need to plan for as we move into the next fiscal year. And so although it seems like every day there's a new change and that there's new executive orders, our priorities still continue to be the same. Our priority is, our number one priority is we want to protect our employees, we want to protect public health, and we want to protect the environment. So the good news is our priorities don't change. It's just the way we have to respond to COVID-19 is something that we have to adjust to each day. And then collaboration is really the key to get through this crisis and every other crisis that follows. By working together, sharing ideas, sharing data, technology, I have found the other speakers today to be so informative to myself and to my team as we want to learn more about the impact of COVID-19 and exposure to wastewater operators. So I want to thank the other speakers today for their great talks, which is very helpful as I share information with my team. And then just want to say in closing, thank you to everyone. And with that, we'll open it to any questions.
Thanks so much, Eileen. Thanks very much to all of the presenters. And we have one more poll question, if we could have that put up on the screen, Monica. What metric do you think best to use to determine a return to normal work practices? So majority voted for the 14 consecutive days of decreased positive individual cases. With a fairly close second was consecutive downward trend in influent wastewater. Well, I guess that wasn't second, actually. Government edict to return to work was second. All very, very interesting responses. And with that now, let's, we will go to some of the questions that were posed during the presentations. And I will try to summarize and pick out some of the most pressing ones that appeared. Should note also that speakers did provide responses in the Q&A box as well to many of these. But I want to, I think in many cases, reiterate them because they're worth everybody hearing in case you weren't able to look in that box. And the first one, I think, is a critical one, perhaps for Rasha and perhaps Chuck. And Rasha, in particular, can you please reiterate whether any additional precautions should be taken by collection system workers because of the SARS-CoV-2 that are different from what they would be doing under normal conditions?
At the moment, our recommendation is that whatever you're doing should be protective, right? Because you're not just protecting yourself from COVID virus in this case. You're protecting yourself from a whole range of enteric viruses as well, Cryptosporidium and Giardia, all sorts of pathogenic bacteria. Now, there has been an area identified where there seems to be some lacking information and where we could give more guidance. In the past, I think OSHA and CDC have given directions perhaps that when it comes to bioaerosol exposure, every plant, every site should do its own risk assessments. And so there's been quite a bit of back and forth on whether or not respirators are required. So this blue ribbon panel that Chuck is actually part of is going to look at bioaerosol exposure specifically, not just for COVID-19, but for all pathogenic organisms in collection systems, in wastewater treatment, and in biosolids. So did I cover that to some extent, Chuck?
Yeah, I think you covered it fairly well. I think, there always is the issue of potential aerosol transmission by other viral agents. I think the concern here is this one is a respiratory virus. So want a little bit more assurance that there's really no significant exposure from a virus that appears to be largely transmitted by droplets from aerosols. So but I think you're right. All the other viruses present probably a greater survivability and risk than the SARS-CoV-2 virus.
Thank you very much. And here's another one for you, Chuck. And this is a question which seems to come up fairly often. And I think you did address it, but I think it's worth reiterating. Can infective virus survive the treatment process such that it is present in secondary or tertiary effluent and or Class B biosolids?
That's a good question. Yeah, based on our initial results, we know it's greater than 90% reduction, but it's not expected to survive very well. This virus is much more susceptible to inactivation than other traditional waterborne viruses like hepatitis A, for example. So we don't see it really surviving, certainly as an infectious agent at all by wastewater treatment, and certainly by tertiary treatment either, because it's a fairly fragile virus and not really expected to survive to any degree, even if it was infectious in the wastewater.
Okay, and that would be true for Class B biosolids as well?
Yeah, Class B biosolids too. The virus is fairly sensitive to heat, so even mesophilic digestion should inactivate it fairly ready. I'm sorry, yeah, biosolids, we don't really see any treated biosolids being any risk at all because the virus is very susceptible to any of these treatments, particularly anything with moderate increase in temperature for a day or two should inactivate it very readily.
Excellent, thank you. And here's one for Amy, just wondering whether CDC might be seeking any partners to participate in the South Carolina study, or is that nearing its completion?
So I don't think we're looking for any additional partners at the moment, but things are changing rapidly. So I would say stay tuned.
Okay, great. If here's one perhaps for Rasha. If N95 masks are really intended for healthcare workers, what is recommended for wastewater workers when they must be within 6 feet of coworkers?
That's actually a really good question. So we struggled with this quite a bit for some of our crews in our remote sites where they had to be in the same truck. While we absolutely respect that they should be for healthcare workers, they are the first exposed. If we're violating social distancing guidelines, then we've been recommending to our staff to put on some respiratory protection. In some cases where if we've got a burst drainage pipe or something in a customer home, we've actually recommended that staff go in their respirators. And we make very clear to the homeowners that it's not because we don't trust you or, you know, that we think you're sick, but it's because if you are sick and you don't know it, you could still be infective to our staff. And in that case, we're not actually taking away from healthcare workers either. But there is certainly a risk perception issue that comes with that. Eileen, have you guys encountered that at all?
We've been allowing just the N95s for our workers, and you know, there's been just the questions, but no, we haven't encountered, and we've been able to get the mask. So we have our workers wearing, you know, the mask or facial coverings if they're out in the field near the sewage.
Great. Thank you. And here's another question for you, Eileen, that I'm interested in as well. Is you mentioned that you are able to test your employees, and wondering, are you testing them on site, and have you had any difficulty in getting those tests?
So because thank you for the question. We don't test on site. There's a location here not too far from our facilities here in Oakland that they can go to. It's set up because we are essential workers, and it's not any EBMUD employee. I prioritize, it's our wastewater operators, our key, you know, wastewater maintenance staff and the lab staff. They get to go, it's voluntary. They get to go during company time, and they can go back every 2 weeks. So it's a matter of keeping them healthy and knowing whether there's the exposure. So it's not on site. I wish we could bring it to the plant, but we don't have that good of connections right now.
Okay, thank you. Here's one for Amy, perhaps. Wondering, is it likely that SARS-CoV-2 mutates, and how bad would that be, and what might that look like?
Yeah, so that's a little bit of a tough question. Viruses can always mutate. However, I would note that we don't think that the mutation rate in this virus is particularly high. So it's not like HIV where a mutation occurs very rapidly. And there was a story that has recently hit the news about a mutation, but the short answer is we don't think that's being interpreted correctly. So we have seen no evidence that it's becoming either more or less infectious over time, mutations or not.
Great. And here's another one for perhaps Rasha or Chuck. Is there, you know, we talked about the treated secondary or tertiary effluent or biosolids, but do you perceive there being a risk for those who may be hydroflushing a manhole where mist or vapors might be created? And I'm assuming that's where N95s and respirators might come in.
Go ahead, Chuck.
Yeah, we're going to be studying that starting next week, actually. So we hope to have some data soon on that. But, I certainly would recommend an N95. That's just my personal feeling, or some other type of respirator or protective gear, because you're creating a lot of aerosol. Not just concerned with the SARS-CoV-2, but other agents in there. So I probably would recommend some type of professional protective gear if you're doing, jetting in the sewer lines.
Right. And then that would be probably normally done as well. And then another question, I guess, just on the wastewater surveillance. Do you see local health departments and/or state governments taking an interest in this? And Amy, maybe this is for you, where it might become a viable metric for deciding or assessing the shelter-at-home policies.
Yeah, so that is our hope for this, that it will provide some additional data, perhaps quicker, to help us evaluate the level of reopening that we should be engaging at for any one community. This is an outbreak where local data is really critical. State level is far too large. You really need information for the community that you're discussing, and this is a good way to get that data. So yes, that is our hope, that we can get this data and relay it to the health department so that they can make those decisions and recommendations as quickly as possible.
Excellent, thank you. And a follow-up for Eileen on your questionnaire that is given. Do you ask about family members with whom employees might be sheltering at home, as well as the employee themselves?
So on the daily symptom checklist, no. But if we've had incidents where an employee, comes to work and says, and one of our employees a couple of weeks ago was at work, and it was around noontime, he got notified that someone in his house got tested positive for COVID-19, who was a medical care provider. And so he left immediately the workplace. He decided he wanted to go home, and he went and got tested and didn't return to work until he found his results were negative, and they were separated. So we're following that. We're working very closely with HR. For anyone who's sick, they go through HR, because HR can ask questions that an individual supervisor can't. So we're doing this through our human resources coordinator, who deals with, who can ask questions that others can't, and it's kept confidential, so that it leaves the realm of a supervisor. Once an employee reports sick, that they've got any flu-like symptoms, it goes to our health coordinator, who then works directly with each of the employees to get the information and to inform when they can come back to work.
Excellent, thank you very much. And I think with that, we can turn it back to Wendy for some concluding remarks. And I'd really like to thank all of our speakers again, as well as all of our participants for joining us on this webinar.
Thank you.
Wendy?
Yes, thank you, Greg. Did you hear me?
Yes.
Great. CWEA is offering opportunities. I think if you look in your chat box, there's some certification programs and webinars that are going on. And I just wanted to say, and I'm going to close this, make this short, but you're all doing so much. You're adapting to changing conditions, supporting your colleagues in the profession, and continuing to protect public health and the environment. Thank you for the essential service that each of you provides. Bravo. So the information from this will be sent out to attendees, and we're going to attempt to capture some of the information in the question and answer. There was so much valuable information. Thank you, everyone. I'm signing off.
Thanks very much, everyone. And a recording of this will be available as well. And thanks to all the speakers and everyone else.